Right, as good evening on this cold, at least here in most of the north, cold winter evening on a Sunday. And this third Sunday, as you know, is reserved for the best things. The best is, beat epilepsy, stay informed, the webinar series. And it's no doubt best, and one of the best chapters is is going to be featuring today in this webinar. And the theme today is extremely important, extremely significant, and the theme is on women with epilepsy. So it is the turn of the best chapter, Jaipur chapter, to present the best webinar uh, here today over the next 1 hour or so. The office bearers, the president, Dr. Sureka, Dr. Anjani Kumar is the secretary, and Dr. Suresh Gupta, the treasurer of the Jaipur chapter, are here. As also the panelists, which I would later request the moderator of today's webinar, Dr. Sureka, to introduce the subject and also the esteemed panelists. As is customary, the esteemed panelists are from the Jaipur chapter, but before that, it is my pleasant duty to first mention a few important housekeeping notes, and also then request our worthy president, Professor Vengamma, to declare this webinar open. So the first thing is request as many people as are participating who are not members of the Indian Epilepsy Association. They should become members of the Indian Epilepsy Association. That is the first thing. Second thing that is extremely important is that there is a feedback form which Dr. Mansi will put it in the chat box towards the end of the webinar, and we request you to kindly certainly fill up the feedback form. As I said, membership, there are lots of benefits, and anyone who is not a member of the Indian Epilepsy Association, we would request them we would strongly recommend that you should become a member. There are lots of benefits. All of these are listed here. Last but not the least, the discussion as would evolve moderated by Dr. Sureka, and the local panelists would take part in the discussion. Others who have questions, who have comments, and I'm sure there will be lots of comments, we would request them to pose their comments and questions during the Q&A session towards the end of the webinar. So with this, it is my pleasant duty to request Professor Vengamma to kindly say a few words and initiate the proceedings of the webinar. We are also pleased here, the President, Indian Epilepsy Society, and the past President of the Indian Epilepsy Association, Professor Mendirata, the President-elect of the Indian Epilepsy Association, Professor Satish Chandra, Secretary of the Indian Epilepsy Society, Professor Manjari Tripathi, are here. I'm sorry if I'm missing out on someone, but with this little introduction, I would now request Professor Vengamma to say a few words.
Good evening to everybody. I feel really honored and privileged to be the part of today's webinar series and the occasion of Golden Jubilee celebration of Indian Epilepsy Association. Today is the 5th seminar and webinar after the successful initiation by the Punjab chapter, subsequently Mumbai chapter and Bangalore chapter, Secunderabad, and today under moderator and leadership of Dr. R.K. Sureka, the Jaipur chapter is doing very interesting topic, that is issues of women with epilepsy. As all of you know that men and women are equally affected. However, nearly half of women with epilepsy, and half of these women are mainly in the reproductive age group, that is 15 to 49 years. And they have a lot of issues. All of you know that 2.5 million women with epilepsy could be there, and majority of them are in reproductive age group. And there are special problems in women with epilepsy related to their reproduction, starting from anarchy, continue until menopause. And they have another issue is lot of social issues, social stigma, and then marriage issues. And they have experienced tremendous social stigma and alienation in life. And despite so much progress, medical, surgical, better social acceptance, with a favorable legal stance, still women with epilepsy are less often married compared to others. And of course, there are some epilepsies common in females, like childhood absence epilepsy and juvenile myoclonus epilepsy. I think there are a lot of issues are there that starts from, like I mentioned, starting with the menarche, menstrual cycle, fertility issues, contraception issues. And most important is epilepsy and pregnancy. And then subsequently, we have issues related to teratogenicity of the anti-epileptic drugs on fetus, and issues also in the postpartum period and subsequent towards the menopause. I think I really thank and congratulate Dr. R.K. Surekha for taking very important topic of issues of women with epilepsy as a panel discussion for today's our 5th best series. And I really thank all the members of Indian Epilepsy Association Jaipur branch for taking this initiative and active participation. I see there are obstetricians and psychiatrists also who are actively involved. I once again welcome all the members, including our IEA past presidents, president-elect, and all the executive members of IEA and IES for active participation. I think today there are many programs, I think, around this time. That's why some people have not joined, like Dr. Bindu, or they're having some other sessions simultaneously. But despite that, many members are there, and a lot of audience I could see in the participant list, because this is a very interesting topic, especially the issues of women with epilepsy. And with this, I thank Dr. Surekha for taking this initiative. And over to Dr. Surekha, you can start.
Thank you, madam. First of all, from Jaipur chapter, I would like to wish everybody a very good evening. And I thank Dr. Vengama and Dr. Gagandeep to provide us this opportunity to come before you. Today, at the onset, Mansi, I would like to just, I'll give you a slide. Could you project that? I'd just like to pay a small tribute to my mentor, Professor Dr. Ashok Pangaria. He was a guru, he was a mentor, he was a guide, legend, scholar, elder brother, friend. We shall not deviate from the path of justice, honesty, sincerity, and serving the poor as shown by you. You might not be present physically, but will remain in our hearts forever. So, thank you, sir. Can now, Mansi, you can just put the slide of today's. I'll just introduce the various speakers to the audience. Today, the panelist, first of all, is Dr. Suresh Gupta, who is the chairman of the Department of Neurosciences at Eternal Hospital in Jaipur. Then we have Dr. Bhavna Sharma, who's the senior professor and unit head, Department of Neurology at SMS Medical College, Jaipur. And then we have another neurologist, Dr. Neetu Ramrakhiani. She's Director, Department of Neurology at Fortis Escort Hospital. Then we have Dr. Priya Agarwal. She's a Senior Consultant Neurologist at Santokha Dorji Hospital, Jaipur. We have a gynecologist on the panel, Dr. Smita Vaid, who is the Additional Director of the Department of Gynecology in the Fortis Hospital. And then we have Dr. Vikas Gaud, who is the ex-professor and head Department of Psychiatry at Mahatma Gandhi Medical College. So thank you very much, all the panelists, for joining us. And now we come to the topic of today's webinar. As you all know, and as Dr. Gagandeep and Dr. Vengammaji has already emphasized the importance of today's webinar, issues in women with epilepsy. As we all know that there are around 70 million people in the world who suffer from epilepsy, and about 12 to 13 million in India. And about 50% of them are women. And out of that, about 52% come in the reproductive age group. So this group is quite a big group. And it actually is very important that the women with epilepsy are facing a lot of challenges. The challenges start from the right teens of the woman when she's very young, and from right the menarche, and then and trying to get married, and then to have a baby, and then to postpartum period, to feed a baby, and then to during the menopause, and then a lot of psychosocial problems, which we all encounter whenever we have to treat these women with epilepsy. And caregivers are very, very much involved, and they are very much worried about their daughters. So we'd like to, today the Jaipur chapter, we'd like to put some light on each one of them. And I'd start with Dr. Neetu, that I have a few patients who say they had developed increased seizures during the beginning of the menstrual period, or some people say during the middle, and some period at the end during the time. So how do you, Dr. Neetu, would explain these, and what advice would you give to the women, to the young females and women with epilepsy and the caregivers, that what they should do? Yes, Dr. Neetu.
Yeah, thank you, Dr. Surekha. So basically, what we are talking here is of catamenial epilepsy. So in the reproductive age group, we know that hormones play a major role. Broadly, estrogen is seizurogenic, and withdrawal of progesterone can also, progesterone is protective against seizures, but withdrawal of progesterone can sometimes bring on more amount of seizures. So there are basically three types of patterns which happen in people who are suffering from catamenial epilepsy. One is what is called as the C1 and C2 cycles, which happen with people with ovulatory pattern, where there is increase in the seizure frequency either in the perimenstrual period or during ovulation. Then there is a C3 pattern where the luteal phase, this happens in the anovulatory population, where there is an increase in frequency of seizures in the luteal phase of the menstrual cycle. So a lot of women notice this association. It is important to identify this association. The approximate percentage can be anything between one third of the seizures to 50 to 60% of the seizures may be related to the catamenial epilepsy. And there can be the basic treatment of these kind of seizures would remain the chronic anti-epileptic drug as per their clinical syndrome. However, for those women who are experiencing increased frequency of seizures during that period, multiple options can be there, although none of them is FDA approved. So one of them is addition of clobazam during that period, where the catamenial epilepsy is seen. The second can be addition of Diamox. The dose can vary from 250 BD to 500 twice a day during that particular period. Or obliteration of the hormonal fluctuations. So addition of progesterone, additional progesterone during that periods, which can be either in form of an injectable progesterone or in form of the oral progesterone. So basically, this pattern needs to be identified. The primary treatment would remain the treatment of the primary clinical syndrome, and additional supplementation can be done as per the clinical pattern of epilepsy.
So, Neetu, that means that the caregivers and the woman who's involved should not worry a lot. This is a part of physiology, and we can easily help them. So nothing to worry about seizures which occur during periods. And now another problem which a woman was married about 10 years back, and she's not able to bear a baby. So Dr. Suresh, could you just throw a light on what she's having and how can we help her and what advice should we give to her? Yes, Dr. Suresh, please unmute yourself. Yeah. Dr. Suresh.
You should unmute.
Yeah, we listen to you.
Okay. Can you hear me now?
Yeah.
Yes,
Can you hear me now?
Yes, yes.
Yeah. Thank you, Dr. Sureka, for giving me the chance to share my views about this problem in young females. Epilepsy per se is not a deterrent against producing children in but you know these patients, they have a low birth rate, and then a lot of other factors, which play in infertility in young women with epilepsy. Apart from biological factors and other social factors like low self-esteem, depression, psychosocial issues, financial issues, stigma associated with epilepsy, fear of passing epilepsy to the children, and fear of congenital malformations in children. All these factors which are responsible for not producing children by these ladies. Certain drugs like sodium valproate, which has a very high incidence of teratogenicity, PCOD syndrome, and insulin resistance, obesity, and all these things, all these factors also play in role for infertility. Enzyme-inducing drugs like phenobarbital, phenytoin, carbamazepine, these drugs lower serum concentration of estradiol and other sex hormones in these patients, and which may also contribute for infertility. Phenobarbital induces, it increases thickness of cervical mucus, which may prevent penetration of sperm in these patients. So, once, if we encounter this type of patient, the seizure type and drug history should be reviewed, and if possible, try to change the drug with very cautious approach. Otherwise, they may throw seizure. So these are the few factors which are responsible for low birth rate and infertility in these patients. A large number of studies like Finland study, Norway study, and US study have shown that the birth rate was almost same in women with epilepsy as compared to the women without epilepsy. And the time to become pregnant, median time to become pregnant at 6-month interval and 9-month interval was also similar in these patients. Thank you.
Okay. So actually, the birth time or that birth duration was same, but it is the prehistory. If the patient has had a lot of drugs, and then definitely the epileptic patients are the infertility rate is a little more. It is less, meaning thereby they are a little more infertile. but that could be very well be helped by proper guidance by neurologists and physicians. Now, I'll come to a most debatable question. Dr. Bhavna, could you just throw some light on this, that women in marriageable age, the parents and women both come to us and ask whether the parents ask whether I can marry my daughter. Second, whether I should disclose the fact that this fact to the groom and the relatives. So what do you think? I'd like to have a consensus from our senior members also. But before that, Dr. Bhavna, could you just let us know what is your view?
First, Dr. Surekha, for putting me in one of the panelists in this important webinar. As you rightly said, this is a very important question, and it has been discussed many times in most of the webinars wherever women and epilepsy is being discussed. But still, it is a debatable issue. And I think the opinion may differ from one expert to another. Some may say that one should disclose, some may say that one should not disclose. If you ask my personal opinion, I'm of this opinion that, of course, the daughter can marry and lead a very normal life, but the girl has to take care of her illness and adhere to the drugs. Second thing, parents should disclose it to groom's family just to avoid future complications like risk of divorce, separation, marital disharmony, and many psychosocial complications. And of course, the role of a doctor is very important in this situation, because it is the doctor who can convince groom's family that this is a normal disease like blood pressure, hypertension, and most of the patients, around 70%, just continue one or two medicines for 2 to 3 years, and it is treatable in 70% cases. It is also the duty of the treating physician to tell the groom's family. Can you hear?
Yeah.
Hello?
Yeah,
Am I audible?
Yeah, you're audible.
Yeah, and it is, it is a duty of the doctor to convince groom's family that every case of epilepsy is not genetic, and the offspring of that girl is not going to have epilepsy. In many cases, it is only few percent that epilepsy is genetic. So by all means, the doctor should try to convince groom's family, and the parents of the girl should disclose, although the doctor can be a bit softer, but a little clear in telling the diagnosis, prognosis, and many issues related to the disease, and to explain them that this is a normal disease and she can lead a very normal life throughout. And I think other panelists may also give their opinion, because as I said, this is an issue when every person may differ in opinion.
Yeah, thank you, Dr. Bhavna. May I ask Professor Satish Chandra ji, if you could give your opinion, what you feel like?
Thank you, Surekha, for asking me to comment on this important topic. As Bhavna has told, this is highly controversial and each one has got their own view. What I do say is that, yes, it should be disclosed. Without disclosing, if you get married, there may be problems in future. So what I suggest is, usually the person who is going to get married should at least know about the epilepsy part in the bride. The reason is, at least if he knows, he should be able to defend her if by chance if it occurs after the marriage in front of the family. That is a very, very important aspect, I always say. And I also offer one more solution, that if there is any controversy or any problem, before they want to know from the bridegroom side, they can come and discuss with me. As a doctor, I would be able to convince them or tell them. I always say a joke that I am not a purohit, but I have conducted many marriages. And this is what I do in many of the people coming with epilepsy in a bride, so that I can convince them and talk to them. And that is the one service I can offer to them. And that is what exactly is to be done. And also IEA chapter from Maharashtra, Nagpur, is doing an human service here. In such situations, they do arrange the marriages also. So that is a very, very important aspect, and we need to help these people because there is still a lot of controversy and also misgivings among the society. And that is what needs to be clarified, and that bride should not be put into that place later on in life. Thank you very much, Sureka, for this opportunity.
Thank you, Professor Satyajit. And really, we are enlightened with what you have said. I'd now like opinion from Professor Mendiratha. Please, if you could guide us.
Yeah, thank you, Dr. Sureka. It is easier said than done. I know what we advocate, what we advise, but in real life, we face different problems. I'm following some of the families where there have been broken marriages. They usually happen in people where the girls are not well educated or the boy is not well educated, especially it happens in that. But I'm also aware of one girl by the name of Miss K is going to get married. The other is an advocate who is married, Miss H. Both are understanding. And the girl has already informed the boy and the family that she has epilepsy. And I don't foresee any problem in that family. The other is a practicing advocate, and her husband is very understanding. But still there is some problem in the family. So if the seizures are well controlled, if there is no recurrence of seizures in the in-laws, where the girl goes to the in-laws, not a major issue. If these are minor seizures, then there is a problem. I'm aware of Miss Nazia, a resident of Kashmir. She consulted me yesterday also. She has become a happy mother of a boy, and the problem comes, she has what they say small seizure, that is temporal lobe seizures with the lip smacking and getting absent minded for short time. So there also, who is looking after the girl? And the grandson is grandfather. So these issues are very sensitive issues. It's not that easily resolved, or there's no good solution through the textbook lines or what we advise. But definitely it differs from person to person. But we know very well it will depend on type of seizure, type of epilepsy, what anti-seizure medicine we are giving, and how many anti-seizure medicine we are giving, and whether in-laws are aware or not. If the girl takes without the knowledge of in-laws, then that is also like hiding something. And tomorrow they may take an offense that why this was not disclosed to us. So when you say face-to-face every day, then there are very different problems than on these platforms. So it's better, as Dr. Satish Chandra said, he is not a Purohit, but he has conducted many marriages. When patient comes to me or people with epilepsy come to me on this, I tell them I'm covering a medical aspect. Then they start fighting or conflict. When you are discussing, you find out there's a matrimonial harmony or family disharmony in this family. So then I say, look, this is a very social issue. They ask whether our daughter can marry or not. I said, she can. She can. But still, it is a social issue. And you should carefully discuss with the to-be partner and with the to-be co-brothers and co-sisters, rather than hiding. So in my opinion, it will be always advisable to have everything on the table very clear and then go ahead. Because in India, marriages are lifelong. Marriage is a lifelong process, and marriages are very expensive in India. It's not like in the West, go to Eiffel Tower, one friend accompanying, a photographer accompanying, take some shots, and marriage is done. Or you go to church, marriage is done. But in India, it's a very, very expensive process as far as finances are concerned, as far as emotions are concerned, as far as culture is concerned, as far as religion is concerned. So mine is that one must devote time, especially on a girl or a boy who is going to get married and he or she is your follow-up subject or patient. They need a lot of time counseling from the doctor, the counselor, family discussion before they take a final call. Thank you, Dr. Surekha.
Thank you, sir, for the advice. And I'd request Professor Vengamma, please, to give her views if she's there. Professor Vengamma.
Thank you,
please.
Dr. Surekha. This is issue is like very easy to said rather than to be practical. Like once in our society, in our system culture, the moment you reveal anything, the marriage may not be possible. At least we see almost 90-95% of the, if the boy has got an epilepsy, the girl may agree or family may agree. But if the girl has got an epilepsy, maybe 10-15% of the people, especially, it may not be problem with the boy, but it is with the his parents and his sisters. They have a lot of issues we are seeing. And at least in our southern, most of the states, they say even if you to have a marriage, they may have tell like 100 lies. That's why even though we tell them that we have to disclose, but most of the girls' parents in practical, they will not disclose. They'll say if you disclose, it will not happen. But when we say the risk that suppose if the things happen, what suppose if there is a break, there's later on misunderstanding, they say as a parent's duty is to get married. But still, of course, practically we have, what you said is that we have to disclose to the boy at least. And at least if I tell them, if they say no, at least it's okay, that girl can educate herself and then become economically independent. Later she can choose her partner, rather than at this stage of financially not so this one getting married and to have a lifelong this one. But I think we should reveal, but practically I don't see in our routine practice 95% of the girls' parents, they will not reveal. Even if they reveal, they will say some just nerve weakness. They won't tell that she has got an epilepsy, needs some sort of a drug this one, because at least in our practice we see most of them, they come with the problems. But of course, this is a parents issue, social issue, doctors issue, we tell them. But ultimately, it is the girl and the parents, they have to take a decision. But whatever the help we need, this one. That's what I'm, though it is a practically, ideally suitable to disclose and do it. But practically in our practice, we are not seeing in 95% of the cases. When we ask also, they say, if you tell madam, they will not agree. That's what it happens. Thank you.
Madam. Thank you, madam. Thank you. Professor Manjari, if you could give your views about it.
Yeah, thank you. Most of the very experienced neurologists have already voiced what the challenges and concerns are. I generally ask the girl whether she wants to get married, and many of the young girls, they actually don't want to get married and want to finish their education. Someone wants to do a B.Ed, somebody wants to do a boutique course. So the first step I do is I ask the girl, and then if she is not willing for marriage at that current stage, I say that I tell her parents that this is the decision she is making now, and one should respect that decision and allow her to complete her course, whether it to be a teacher, whether it to be a beautician, whether it to be some kind of candle and wax making business, etc., etc. So that gives them little time, and I tell them that this job which she does is going to help her throughout, because I have seen that as Dr. Vengamma said, that majority of people who disclose marriages are difficult,
And even after disclosure, I have seen, like Dr. Satish Chandra was saying, the person she's going to get married to has to be told about the problem. I've had young girls telling their husbands to be that they have epilepsy, and the husband to be has accepted it. But then in India, you do not marry just the husband. You actually are getting into a family system. So when the marriage is over, after a few years, the husband husband kind of discloses it, or the family kind of finds out. So even though the husband may have been supporting in the beginning, the family nudges him to kind of leave her. So I think the most important thing is to get the young girls there and tell them that first they need to be standing on their own feet, and they should have an attitude of, they should have a plan B in their mind. The plan A is, of course, the marriage, provided the girl wants it. And the plan B is that what if, they trouble me, or I'm left in the lurch and I've sent back to my parents' house. What is my plan B? So these are the two things which are very important for that girl. Now, I also tell the parents that why do you want to get your girl married? So that she's happy and she's looked after and she receives unconditional support, which, seems to be a miracle if that happens. So wait for her to, get her feet up and going. Then, of course, I tell them that if she didn't have epilepsy, you would probably look at 10 people before you narrow down one whom she's going to get married to. And if she has epilepsy and you disclose before marriage that she has a problem, but she's controlled and she can have children and get married, then you probably have to look for 100 people. But after looking at those 100 people, you'll at least find one who's willing to accept her. So I think, telling them that they may have to search a little longer and search wider, and also telling them that the girls need, to be financially stable in whatever way it means to them. I think these are two important things. And my last take is, that marriage is not like eating a laddu and you eat it and everything is going to be fine. There are new challenges posed after marriage, in terms of adapting to the family, which the girl has to do mostly. And of course, the fact that if they have children, looking after the children. So really is everything in preparation for that. Some of the people understand it. Some of them still get their girls married without informing. And they do come back with tears in their eyes. So I think this whole concept of marriage being the holy grail, is something which really needs to be looked at. And the recent, thing which is going on, that girls' age of marriage should be raised to 21. I think that is going to be also good, because I don't want to enter into the politics of it, but if they're going to get married a little later, they'll have more chance of getting into some educational program or some vocational course which will kind of give them some financial autonomy. Thank you.
Thank you, madam. Finally, I would like Professor Gagandeep, if you could throw a light on what you say. Professor Gagandeep.
Yeah. I think a lot has been said by all the experts, and we had some years back, looked into this in great amount of detail, and we had, brainstormed this with lots of experts. So I think the key thing is, not at the cost of repetition. A lot has been said, and I think it's extremely important. What all has been said is I completely agree with that. But one needs to be very proactive about it, and therefore this discussion on marriage needs to start very early. That is the first thing. Discussion on the future course of action, and as Dr. Manjari, Dr. Satish Chandra, Dr. Mendiratta, everyone pointed out that it's extremely important, particularly in the arranged marriage system that we have in India, it's extremely important to empower the girl, right? It's like a point system. I always feel it's like a point system. When they look at the boy, they look at how tall is he, how handsome is he, how much does he earn, what kind of family does he come from, what is his educational background. And likewise, there are a number of points. So there are plus points and there are minus points with everyone. The other thing is, if we are very proactive about it and start the discussion very early, we will realize that the first feeling that is there in the minds of most families of women who would like to get married is fear. And the fear is that, oh, doctor, who would get married to us? Why would, I think it's just impossible. So you have to gently, take them and goad them out of this fear. And the fear of disclosure is even more than the fear of, uh, feeling that one is not possibly going to get married. So we have to kind of convince them. We have to really make them strong. We need to make the families believe in themselves, believe in their daughters' abilities, their daughters' plus points, daughters' merits, which would be many. I mean, epilepsy would be one thing, but then there are every person has good points and strong points and minus points. That is true for everyone. So our role, as I see it, is in bringing up the issue early, having free and transparent and honest discussion about the issue, and trying to encourage the patients, the women with epilepsy, the girls with epilepsy, and their families, that this is, I mean, don't fear about this thing, don't worry about this thing, to the extent that you are not even trying to look for a match, you know. So that is something that I feel which should be very helpful, and we need to encourage them, and if they have the strength, they have the willpower, they have the strength of mind, I see no way that you have to take the step, and only then you would succeed. If you don't fail to take the step, then they are not going to succeed.
Thank you. Thank you, Dr. Gagandeep. We have had the views of our senior persons, and I thank them all for their considered opinion. I'd just what my opinion is what is already been said, and I agree with Dr. Manjari that one has to empower, and Dr. Gandhi also, that one has to empower the woman and have to make them financially stable. And maybe if we start early counseling to the parents, that the patient may be treated properly, and maybe she might be seizure free by the time you marry her, and then, or her seizures are controlled to the aspect that she has very little of medicines. So I think we can all follow what has been said, and thank you very much, everybody. Now we go forward, and I'd like to ask Dr. Vikas, what are the social issues, other social issues, which women with epilepsy have faced besides marriage? So could you just spotlight?
So first of all, thank you, Dr. Surekha sir, for including me in the panel and giving me the opportunity to speak on this very important platform. Sir, women with epilepsy tend to have worse social and economic status in comparison with the women without epilepsy. These women may face several social issues related to education, marriage, employment, divorce, driving, etc., and which may vary at different stages of their life. And sometimes these issues are often more problematic than the seizures themselves, especially in cases of untreated epilepsy. For example, there is a high school dropout rate in school-going female epileptic patients, and the reason could be the parental fear regarding their security at school. What if they will have seizures in the school, as well as discrimination and rejection by their peers and teachers. In adolescent female patients, stigma and fear of discrimination, as well as anti-epileptic drug-associated side effects such as weight gain and hair loss, may lead to social isolation, resulting in poor social interaction and interpersonal skills. Among adults, we have already discussed about marriage. And one very important social issue is related to employment. Women with epilepsy usually have high unemployment rate. Choosing an appropriate career is also difficult for them. Even if employed, they may face significant stigma and discrimination at their workplace and are usually not given duties or responsibilities. However, a good thing is that all these issues are amenable and can be dealt by proper counseling, psychotherapy, and support in most cases. So these are some of the most common social issues which are being faced by women with epilepsies.
Thank you, Dr. Vikas. Now, Dr. Priya, you just what advice do you give about contraception? How to women with epilepsy, and how is it different from normal women? Dr. Priya, please.
Thank you so much, sir. Contraception in women with epilepsy on anti-epileptic drugs, especially the enzyme inducers, is difficult. Pharmacokinetic interactions between the anti-epileptic drugs and the oral contraceptive pills are bidirectional. As such, non-hormonal contraceptive methods should be prescribed in such women. If at all hormonal treatment is to be given, it has to be estrogen, the ethinyl estradiol, the starting dose of which has to be around 50 micrograms per day. However, full contraceptive efficacy cannot be guaranteed. Emergency contraceptive pill may be given. Progesterone only pill is likely to be ineffective, but depot injections of medroxyprogesterone acetate may be given. For women on non-enzyme inducing anti-epileptic drugs, all contraceptive methods are suitable.
Okay. So, Dr. Vaid, do you have any other opinion, or what are you advising to your epileptic patients? Could you share your experiences with us? Dr. Vaid? Dr. Vaid, could you help?
Good evening, sir. I do agree with Dr. Priya. With enzyme-inducing anti-epileptics, the choice is either a non-hormonal contraceptive like IUCD or copper T, or the barrier methods. If a combined oral contraceptive has to be prescribed, it has to have higher dose of ethinyl estradiol plus a combined progesterone. Sometimes a cyclic contraceptive pill may also be prescribed. With non-enzyme inducers, any of the hormonal contraceptive can be given. A depot preparation of progesterone, which is Depo-Provera, is good contraceptive for enzyme-inducing anti-epileptics as well.
Okay. So, Dr. Suresh, soon after marriage, women with epilepsy normally come to us and say whether they can have a baby or not. So, what would you advise, sir? What precautions she should take at the beginning?
This is the most important aspect. Counseling is of paramount importance. And as a matter of fact, the counseling should be started even before marriage itself, at least 9 to 12 months in advance. So these whenever these patient of epilepsy comes to us, first of all, ascertain the seizure type, what type of seizure she has and what type of drug she is taking. The drug treatment should be reviewed. And then contraception aspect should be stressed in once they get married. So as our esteemed panelists said that hormonal contraceptives should be avoided in this patient. Non-hormonal contraceptives should be advised if patient is on enzyme inducer anticonvulsant drugs. This should be told about benign aspect of epilepsy, and the counseling should start on a positive note, stressing that they can have a normal life, they can become pregnant, they can deliver child, and they should be told about uneventful pregnancy, precautions to be taken in pregnancy, and then finally breastfeeding and care in postpartum period. Within postpartum period, many of them do develop depression and other psychosocial issues. So, then about drug therapy, particularly sodium valproate, should be avoided, and if they are taking sodium valproate, then the dose cautiously should be reduced to the minimum effective dose. And drug level monitoring should also be still very important in these patients, particularly in patients who are on non-enzymatic antidepressants, anticonvulsants, and lamotrigine. Lamotrigine is a very important drug. You know, this in pregnancy, because of high estrogen levels of lamotrigine drops down to by more than 50%. So, and if the level drops and we don't know about the level, exact levels, then they may throw seizure during pregnancy, which may be detrimental for the patient as well as for the fetus. So all these about their fear about transmitting disease to the fetus or their child should also be discussed at length, because that the incidence of transmitting disease, epilepsy, is not very high, it's very less, unless patient is having some epileptic syndrome, genetic epileptic syndrome. So all these issues should be discussed, and patient should be counseled about this. Polytherapy should be avoided in these patients, because polytherapy is by and large associated with very high incidence of congenital malformations. Sodium valproate is one notorious drug which is associated with the high incidence of neural tube defects and other major congenital malformations. Then phenobarbital is also associated with cardiac defects, and topiramate can also be associated with the cardiac defects. So as far as possible, one should avoid, or if at all it's compulsory to use these drugs in women with epilepsy, then the dose should be kept minimum, which can control seizures in these patients, so that we can avoid complications in these patients.
I think Dr. Suresh, you have mentioned most of the things, but maybe a tablet of folic acid could always be supplemented.
Yeah, I'm sorry to mention, the folic acid is very important. The folic acid should be started in a pre-conception period itself, well in advance.
Yeah. So now I'd request Dr. Vaid, how is the antenatal labor different in women with epilepsy from a normal pregnant woman? And does all women need cesarean section, or what is your experience?
Then ideally, the antenatal care should start even before conception, with changing the drug to the lowest level of the most appropriate drug and putting her on folic acid. She should be guided to take a well-balanced diet and to check her lifestyle with daily walks and exercise, so that we can keep the risk of other obstetric complications at low. So once she is pregnant, she is duly counseled regarding the side effects of anti-epileptics and the effect of seizures on her pregnancy. She is monitored throughout her pregnancy with particular attention to her NT scans at 11 to 13 weeks for neural tube defects, and anomaly scan at 18 to 20 weeks to detect other anomalies. A growth scan is also conducted at regular intervals. She is checked for seizure frequency and guided to elevate the precipitating factors of seizures like inappropriate sleep patterns, inadequate sleeps, inadherence to her anti-epileptics, stress. And then when she is through labor, the diagnosis of epilepsy per se is not an indication for cesarean section or for early induction of labor. It purely depends on her obstetric indications for cesarean, though she is monitored very closely in her labor, and it is important to give her adequate support in the form of an attendant who actually accompanies her through the process, and epidural analgesia or other form of pain relief. It is the particular attention is also paid to hydration and to elevate her sleep and stress patterns. Sir, if a seizure does precipitate in labor, it has to be mitigated promptly by a suitable anti-epileptic, and the fetus has to be monitored for hypoxia and acidosis with continuous fetal monitoring. If the seizures have not deteriorated during pregnancy and there is no risk of status epilepticus, we usually give a trial of normal labor and do not opt for a C-section.
Thank you. Dr. Bhavna, what are the challenges while selecting anti-seizure drugs in treatment of women with epilepsy? And what do you think is the safest drug to treat the woman?
Thanks, Dr. Surekha, for this question. I think there are many challenges when you treat a woman with epilepsy. That is why this webinar is being held today. We are not talking of men with epilepsy and challenges. So the topic itself reveals that there are many, many challenges when you are treating a woman with epilepsy vis-a-vis a man. The reasons are manifold. A woman has to pass through many cycles in childbearing age, from puberty to pregnancy, lactation, and subsequently menopause. So one has to be aware about the proper set of drugs. Choosing safer drug is most important. Any drug which has side effects or adverse effect on the baby should be avoided. So it is, the first thing is that in first decade of life, it is not necessary to be very cautious and you can choose the drug freely. But around puberty, if someone is seizing, then one has to avoid sodium valproate because it can produce anovulatory cycles and it can also cause PCOD. Subsequently, during pregnancy, the drugs which have teratogenic potential like sodium valproate, phenobarbital, topiramate, phenytoin, and to some extent carbamazepine should be avoided. There are drugs like lacosamide and clobazam, the safety of which is not fully proven. So one should try to avoid all these drugs during pregnancy. And the safer drugs include, first is lamotrigine, followed by levetiracetam, and then comes oxcarbamazepine. One also has to see the type of epilepsy which is being treated. If it is juvenile myoclonic epilepsy and valproate is essential, then one should try to give valproate in low dose below 500 milligram a day. And around menopause also, you have to take care of bone health also. So the proper selection of drugs, taking care of side effects is very important while treating an epileptic woman. And of course, nonetheless to say that lamotrigine has been found a safer option in pregnant and lactating ladies, followed by levetiracetam and oxcarbazepine if it is a partial onset seizure. Thank you.
Now, as we all know that JME is an important problem in women. And so, Dr. Priya, could you tell us how do you deal with a patient of JME when she comes, is young to you? And could you stop her drugs totally? Can you try that?
So valproate remains the gold standard in the treatment of JME. But as we all know, valproate is considered unsafe for the fetus because of its teratogenic potential and also the potential for low IQ in the offspring. It still could be given in women who are outside the childbearing frame, though it still could have deleterious effects on the reproductive health. Lamotrigine in women of childbearing potential is a very good alternative, and the safety of lamotrigine in pregnancy has been established. Levetiracetam too has emerged as a good alternative, and again its safety has been established lately. Clobazam has a low teratogenic potential and as such could be considered as an add-on when the seizures remain uncontrolled with the drugs as lamotrigine and levetiracetam either alone or in combination. When seizures are non-responsive to these drugs, valproate could be given, but then it has to be given in the lowest possible dose and as far as possible as monotherapy. Last but not the least, all anti-epileptic drugs in women with epilepsy need to be supplemented with folic acid. Now, regarding the second question, how long the treatment is to be given? So, as such, treatment in JME is considered lifelong. Even if we do not consider a lifelong duration as the treatment for JME, still it has to be reasonably long. And this age from puberty to say up to 40 to 45, this is a very, I would say ki it is very happening. The girl has to study, become financially independent, then she gets married, then of course it is the children, then jobs. So at least this age she should not be predisposed to getting a seizure. So at least this age needs to be covered fully with treatment, and after this age passes we can still give her a trial of anti-epileptic withdrawal, though it has to be usually lifelong.
Thank you. Now, I like to put in an aspect of pregnancy in epilepsy registries. I find that as far as my search has gone on, there are very few registries which are functioning in India. Especially only the Kerala one is doing quite well, and it's a very big registry. So I would like to have opinion of our senior members regarding what I thought I just proposed, that could Indian Epilepsy Association, we have a lot of chapters, and could each chapter have a pregnancy and epilepsy registry in which could be guided by the secretaries and persons who are interested in them, and we can have a Google form which could be filled up by most of the people of that state, and we could gather a lot of information and we could guide the pregnant woman also. So, Madam Vengama, could have your opinion, please, regarding this suggestion. I have a suggestion. Madam Vengama? Madam Vengama is, maybe I'll ask Dr. Gagandeep if you could give us your opinion.
Yes, ideally what you're saying probably needs to be done. Of course, the Kerala registry and some people have done good work outside Kerala too, but certainly Dr. Sanjeev Thomas and his entire team need to be given the due credit for at least having come up with very good data regarding the information that the findings of the Kerala registry have been really informative, and in many ways they are similar to global registries and registries in other parts of the world, but then there are some unique findings too. So I think but what you're saying is right. There are newer drugs, new medicines which are coming up, new medicines for which we do not have enough data during pregnancy. So I think, yes, perhaps maybe the Jaipur chapter takes the initiative and starts the whole thing, and we would all love to follow.
So I just was wanting your opinion that could there be a role of IEA for improving the health of women with epilepsy during pregnancy by requesting all the chapters to have registries of the states?
Yes,
pulling out the data online on a central platform.
Yes, the IEA is committed towards the health of women with epilepsy, and it has a deep commitment. There is no doubt about it. We need to work out how to get funds around for this project, because it needs to be sustainable over a very long period of time. But this is something that needs to be done. I completely agree with you.
I'll request Dr. Satish Chandraji to give his opinion, please.
I think it is a, am I audible?
Yeah, you say you
It is a very important thing, and we have learned a lot from Kerala chapter, Dr. Sanjeev Thomas, who did this and who has done successfully. We have a very useful data from the Kerala chapter. We have all learned a lot. There are many investigators who are also participant in that Kerala chapter initially. Dr. Venkateshwaralu from Visakhapatnam, Dr. Vengamma, and others are also participated in that. So it is now time that we need to have IEA taking up this important activity, because we are talking about 50% of our population who are women and who have a role to play in this world. And that is the reason this has to be, this sense being a challenging aspect, we need to, IEA should take it up and then look it up from different chapters. And also there are regional differences. In India is a big continent, it is almost like a continent. It is not a country. It is, I always say, India is a real United States with 31 or 36 states which we have now. Each state is different from the other. So what we require is we need to have a policy of uniformity, plus at the same time to understand the differences or diversity which is there in the population and to learn more about it. It is essential. The IEA could frame a part of it, and then we can think about it in the coming years to have a regional participation and having a registry all over the country. If not country, at least in some of the states in the region, we can have that and contribute to the world, global data also. It will be very, very useful. Thank you very much, Surekha.
Yeah, thank you, sir. Professor Mendiratha, could we have your opinion about that?
It's a good idea. I've heard Gagan and Satish mentioning about it, because whatever ultimately the people with epilepsy will be under the follow-up of professionals. That's doctor, usually neurologist and gynecologist. So if you wish to have this mega planning, it should be in conjunction with Indian Epilepsy Society, because normally IB, what it advocates is should be a group of non-medical personnel. So there are both aspects, social, economic, as well as the medical aspects. So it will be a very good idea to have under the umbrella of Indian Epilepsy Society and Indian Epilepsy Association to have a registry. We all have database. When I was in GB Pant, I was also collecting data, but somehow didn't publish. And Sanjeev Thomas did a good job by publishing it. And with Thompson, it was, there is a book on this at international level. So, and Marriage and Epilepsy, Gagandeep published when John Duncan has come to Ludhiana. So what I will suggest, it should be Indian Epilepsy Society and Indian Epilepsy Association taking the initiative together. And if we have few thousand subjects or person with epilepsy or people with epilepsy, it will be a landmark achievement. Thank you.
Thanks. Madam, may I request Professor Banjari to give her opinion, please?
Yeah, so, you know, I think we've got a lot of information on pregnancy safety issues from the registries. I also think that the newer drugs are being followed on, like lacosamide, brivaracetam. I think life is much more than just pregnancy. So I feel if Indian Epilepsy Association and Society have to work together, we should work together in building resource persons, particularly counselors. We need epilepsy counselors at the ground level. So we really need to, you know, build up a cadre of people who are non-medical, who could be social scientists, who could have some science background, who have some kind of formal training done by the doctors of the Indian Epilepsy Association and Society. You know, we build up a cadre of such people who can assist us in not only jotting down the data, but also in counseling. I think that is the way to go rather than a very, we have the scientific information, and these registries are continuing to follow patients. So I think we need to go a step further than just documenting whether the pregnancy outcome is safe or unsafe, or there were malformations. I think limiting a subject to just pregnancy is too narrow. And I think the Indian Epilepsy Association should evolve into generating resource persons who can help all of us, whether we are in the private sector or in the public sector. And it can be done online. It can be, and now we've explored the Zoom platform. We've explored, so it's so easy now to actually train a resource person and get them to counsel people. So I think that is the way to go, and they could also help us jot down data. Thank you.
Yeah. Madam Vengamma, if you are there, could you give your opinion if you are there? Okay. So now let's go forward. And Dr. Ved, what a woman near delivery asks her gynecologist that whether she can feed her baby as she's taking us anti-seizure drug. What do you tell her normally?
So the benefits of breastfeeding, they far outweigh the theoretical risk that the anti-epileptics pose to the developing baby's brain. The blood-brain barrier is still immature, and exposing it to the toxins of anti-epileptic drugs may affect the cognitive function. But the nutritional, developmental, immunological, and psychological benefits of breastfeeding, they are much more important to the baby than the theoretical risk of anti-epileptic drugs. So we guide the patient, counsel her to keep feeding her baby. If the baby shows some signs of drug exposure like increased somnolence or drowsiness or inconsolable crying, and we suspect it to be due to the anti-epileptic drug, then we ask her to observe after a period of breast feeding free period, and if the symptoms reappear after she has resumed breastfeeding, then we guide her to feed the baby. Once we guide her to take the anti-epileptic drug immediately after feeding the baby, or when the baby has to sleep for long hours, then she should take her anti-epileptic drug so that the baby is not exposed to very high levels of drug through the breastfeed.
Okay, now we come to another problem. Dr. Neetu, how do you encounter, how frequently do you encounter need or history of epilepsy in women with epilepsy? And what do you do in such cases if they are pregnant and you suspect a need?
When we suspect a non-epileptic seizure, we have to put it into two categories. One is a category where there is true seizure and a pseudo seizure. If it's a true and a pseudo seizure, in that case, the anti-epileptic drug has to continue. If we feel that it is only true, all the seizures are pseudo seizures, and even after careful interviews, careful recording, careful discussion, and all the records, we find no evidence of true epilepsy. Most of these patients carry a label of refractoriness. It will be reasonable to gradually withdraw the anti-epileptic medication and initiate them into a proper counseling session. The discussion has to be in a non-judgmental, friendly way, giving them explanations and withdrawal of medication in a gradual fashion. In fact, there has been some data and some literature where they have charted out how to withdraw, which has been found to be reasonably safe. There is no point exposing the child to excessive teratogenicity.
Okay, then Dr. Bhavna, what do you think is the effect of menopause on epilepsy?
Yeah, Dr. Sureka. Menopause is a time when there's tremendous hormonal fluctuations going on in the body of a woman. At this time, the level of estrogen is considered an excitatory hormone and a seizurogenic potential. And the progesterone increases, which is considered a calming hormone and ideal reduction in frequency of seizures. This is seen in catamenial epilepsy, where the chances of having seizure at menopause decreases. But otherwise, in other cases, the seizure occurrence still continues. Another thing is, at the time of menopause, you have in selection of drugs, because any drug which affects bone health of a woman should be avoided. So this is the situation with menopause. And you also have many comorbidities which occur at the time of menopause and which can produce seizures. Selecting the right drug, and one should try to avoid drugs like phenytoin and carbamazepine, sodium valproate, which affects the calcium metabolism in the body of a woman, and should select a better drug. Second thing is that the drugs which have cognitive side effects like lacosamide and levetiracetam should also be given low priority at this age.
Dr. Vaid, are you trying hormone replacement in patients of epilepsy and menopause and having difficulties?
Sir, as we have discussed that estrogen is a pro-convulsant hormone and progesterone has a calming effect. If the lady is undergoing menopausal symptoms because of estrogen deficiency, giving her HRT rich in estrogen may be detrimental to her seizure profile. So we usually avoid HRT and manage with counseling, supplements like calcium, vitamin D for her bone health, and counseling for the general upkeep of her health like diet and walk exercise. Maybe some natural extracts which have phytoestrogens may help her through menopause during menopausal symptoms.
Okay. And Dr. Neetu, have you come across a few women with epilepsy who are trying to have baby? They say that will each baby be epileptic one? If they have had one epileptic baby, they come again that the next baby would be epileptic. And then if I should decrease the dose of drugs, or should I stop the drugs if I bear a baby? So what's your opinion about it?
See, we have to review the epilepsy syndrome. If it's a symptomatic epilepsy, like seizures in a person with a tuberculoma or a neurocystic psychosis, we can reasonably assure the lady that most of these seizures are non-genetic seizures. On the other hand, syndromes like IgE, they do carry some genetic risk. So in a general population, the risk is 0.5 to 1. Here, the risk would be somewhere around 4.5. But on the whole, the risk should be presented in an appropriate context. The second part is the risk of teratogenicity because of the medications they are taking. So the medications, they should be reviewed. The dosage, they should have to be counseled for the dosage, for the nature of drug, and the counseling has to be there so that the fears can be addressed in both a scientific and a logical. So that is what we would do.
Yeah. See, actually, when a woman comes and asks us these questions, normally what I do is I normally tell them that the risk is only a little bit higher, but there's no risk that your all babies are going to be there. So that she's consoled. And whether we have now got newer drugs that are very less teratogenic. So that way we console the patient. So next, Dr. Vaid, what do you think after delivery normally and after postpartum, the patient comes and has increase in seizures? So how do you tackle that problem? They must be coming to you.
So adjusting the dose of anti-epileptics, she has to manage in tandem with the neurologist. But then we counsel her and the attendants that attention should be paid to the support system that she has and to elevate the precipitating factors that could be inadequate sleep and stress and dehydration. And so those things have to be taken care of. And whatever her apprehensions regarding breastfeeding, they have to be laid to rest.
Yeah, Dr. Suresh, what's your opinion? What do you do when the patient comes to us? Normally we get the drug levels and increase the dose of certain drugs, which might have decreased, and some drugs increase. Suresh, can you hear me? Yeah.
Can you hear me now?
Increase in seizures.
Yeah, this is particularly true for lamotrigine and oxcarbazepine. The drug level should be done.
Yeah.
Because there will be a lot of fluctuations in drug level. Pregnancy, at the time of pregnancy, the level will be different, and in postpartum period, the level will be different. As Dr. Ved rightly said, that it should be managed in tandem with neurologists, of course. And then psychosocial support should be provided. Sleep deprivation should be minimum possible. And other family members should also take active participation in taking care of a child. Usually, these females, while taking care of a child, they remain sleep deprived in the night time, and because of sleep deprivation, they may throw a seizure.
Yeah.
Drug level monitoring plays an important role in these patients.
Yes, Dr. Vikas, could you let us know what are the emotional effects of women with epilepsy, and how there's a question in the chat box that how much psychosis is common in such women?
Sir, as we all know that psychiatric disorders and epilepsy has a bidirectional relationship, and women are no exceptions to this. In fact, psychiatric disorders are very common in women with epilepsy, ranging from 20 to 60% according to various estimates, and which could be because of the effect of seizures on brain, psychiatric effects of anti-epileptic medications, as well as unpredictability of seizures episode and a permanent state of being labeled as epileptic, resulting in loss of self-confidence and self-esteem. Most major psychiatric diagnoses among women with epilepsy are depression and dysthymia, in fact, affecting 1 of every 3 patients with epilepsy in clinical studies. Then women with epilepsies are at increased risk of developing depression, especially before and after pregnancy, especially in second trimester to 6 months postpartum. Then there are very high incidence and prevalence of anxiety disorders, psychosis, both pre-ictal, periictal, post-ictal, and interictal, bipolar disorders, hysteroepilepsy, which we have already discussed, and suicide. In fact, 2.6 to 5 times higher than in general population has been noted in women with epilepsy. Then there are cases of cognitive impairment. Regarding psychosis, there are 2 types of psychosis. First is interictal psychosis, which has symptoms similar to that of schizophrenia, mostly consisting of positive symptoms. And then the other type of psychosis is around epilepsy, that is pre-ictal, post-ictal, and ictal. These types. In pre-ictal, and the prevalence is something around 5 to 6% cases of psychosis has been seen in epilepsy to generalized tonic-clonic epilepsy.
Yes.
So I'm audible. Can you hear?
Yeah, please, your net connection is a little weak, I think. So we switch on to the last question, and we'll wind up our session on this woman with epilepsy. Dr. Suresh, could you, how is bone health affected in women with epilepsy? And this would be the last question. And Doctor, I'll request Mansi to send us the questions if any are remaining still to be answered, so that we can put them on the website.
Yes.
So, Dr. Suresh, please.
As Dr. Bhavna mentioned, that menopause, the bone health gets affected. Use of enzymatic inducer drugs, like particularly phenytoinvisible notorious drug, which interferes with phenobarbital, carbamazepine, and sodium valproate. All these drugs, the sodium valproate, though it's not an enzyme inducing drug, but it also reduces bone health in in not only in females but as well as in males. Particularly in females in menopause time, due to hormonal change, and the estrogen level goes down. So estrogen is a very important substrate for calcium metabolism, and the calcium gets deposited only with the help of estrogen. If estrogen is lacking, then the calcium deposition will not occur in the bones. So these patients, they should be screened for the bone health regularly, and they should be given vitamin D as well as calcium. Vitamin D, if it is, can be given in 800 units to somewhere around 4,000 units daily.
Thank you, Dr. Suresh. And we come to the end of this webinar session. And on behalf of Jaipur chapter, I would like to thank all the participants, our very senior members of the association, and the panelists. And I would now give it back to Dr. Gagandeep for his next command or his next things.
Dr. Mansi, if there are questions which you could direct to Dr. Surekha and the panelists. Meanwhile,
I will do that.
Meanwhile, I would request all who are attending to kindly fill up the feedback. That is extremely important for us. And also to remind you that the next session is going to be conducted by the Delhi chapter on January 23rd, which is the third Sunday of January. So we look forward to seeing you all on January 23rd. Again, reminding everyone, if they're not members of the Indian Epilepsy Association, to kindly go to the website. Dr. Surekha is also the treasurer of the national body, and therefore all the money has to go to him eventually. So request everyone to, whosoever is not a member, to do so. Dr. Vengamma is here. So any closing comments? Before that, are there questions, Mansi?
There are some questions, I think somebody has asked.
Right.
Yes, sir. There are a couple of questions.
Yeah, Dr. Surekha, would you?
Yeah, if you want, I can still continue.
Kindly direct them to.
I'll direct them to Mansi and she'll put it on there.
Okay, so you would answer them. You're not answering them right
No,
now.
I can answer them just now if you permit this time, you know.
Okay, so you would like to do it on the website.
Yeah, I can do either way.
Some of them are personal questions. I think we should take them up at a different platform.
Fair enough. Fair
Yeah.
enough. Okay. So your concluding remarks and then concluding remarks by Dr. Vengamma, and thereafter we conclude.
Thank you.
Yeah, it's. I really congratulate Dr. Surekha for wonderfully organizing, covering all aspects of issues of epilepsy in relation to the woman. I think most of the questions you have covered, and all your panel members also have appropriately replied everything. I think nice program and wonderfully organized. Congratulations and thank you, Dr. Surekha, once again. Maybe I think one or two questions like what Dr. Manjari said, somebody has written like saying non-epileptic seizures, how I should get control. Some persons have written what is the part of the breastfeeding should go ahead. Some sort of personal, this one I think we have to this one. Some have asked like most women with epilepsy on medicines are permitted to continue with their seizures. You should consult your doctor who is. Some of these issues are I think personal, you can reply to them in their website. I think once again, I think we have already almost 1.5 hours. And thank you, Dr. Surekha, and all your team of panel members for having conducted this webinar on issues women with epilepsy. Thank you once again.